Hello, and welcome back to Be a Loser. Previously, we discussed why there is no cure for type 2 diabetes. If you remember, this is a disease that has been recorded for many hundreds of years. It was actually quite well controlled even 100 years ago. But we now find ourselves in an epidemic of T2D that appears to be a freight train out of control and barreling ahead into oblivion. We discussed how greed is what's truly driving that train, but even if the powers that be don't want a cure for the disease, shouldn't we at least be able to control it better than we are with modern medicine and technology? Well, the problem with that lies in the flawed concept of how and what to treat with T2D. In order to answer that question, we must understand the mechanisms of obesity, the markers of type 2 diabetes, and how lowering blood sugar is actually making people more sick. So as we know, obesity is very often the herald of impending T2D. Not always, as we saw in a previous video, but often. So the natural conclusion is that obesity is a main cause in metabolic syndrome and a marker of disease. Metabolic syndrome, as you may recall, is a clustering of at least 3 of the following medical conditions: abdominal obesity, high blood pressure, high blood sugar, high serum triglycerides, and low levels of high-density lipoprotein, or HDL. But obesity is in reality the body attempting to protect itself from the disease. I know. How can getting incredibly fat be protecting me against anything when I'm told by every doctor, friend, and family member I know that I'm going to die of a heart attack if I don't lose weight? Well, let's look more closely at the process of becoming obese. There's a rare disorder known as lipodystrophy in which the body cannot produce fat. There was one very famous case of this just a few years ago that was covered by New York Times journalist Gina Kolata. In this article, Gina describes the case of Claire Johnson, who suffers from lipodystrophy. Claire was always hungry and very, very skinny because she did not have fat cells. Even though she was so skinny, Claire found out that she had a huge fatty liver, polycystic ovaries, and incredibly high triglyceride levels. These should sound familiar to anyone diagnosed as obese, as they're all markers of obesity. Claire was diagnosed with lipodystrophy by Dr. Simeon Taylor, who had several other patients suffering from the same disorder. These patients had the worst insulin resistance he'd ever seen, but not one single subcutaneous fat cell that he could detect. These patients typically developed high blood pressure and T2D, which, as we know, are associated with obesity. So once again, one would think, well, there you go. The obesity is causing all these problems. Aha! Not so fast. In studies of rats with lipodystrophy, when the rats had some fat cells transplanted into their bodies, lo and behold, their metabolic syndrome disappeared. The fat was actually protecting the body from insulin resistance rather than causing it. So, if the obesity isn't the cause of the disease, then what is? Well, we know that it's the hyperinsulinemia, or high blood insulin. To understand the nuances and mechanisms of insulin resistance, please refer to my video on it. What's important for this video is that when the liver has too much glucose and fat, it tries its hardest to move that fat out as triglycerides. Normally, this is done by sending the TG to the fat cells. These cells, known as adipocytes, are specifically designed to store this fat. Having more of these cells isn't particularly bad. Other than taking up a lot of space, all they really do is hold fat. That's their purpose. Now, they have another purpose as well. When these fat cells expand, they release leptin. Leptin is a satiety hormone and signals us to stop eating. Unfortunately, when we're obese, we're constantly stimulating leptin release, and as we know from my IR video, constant stimulus leads to resistance. So over time, we become leptin resistant and our hunger returns. Now, being obese isn't really a problem as long as all the fat is in the adipocytes. The real problem occurs when you get fat where it isn't supposed to be. Fat in the organs. Visceral fat. First, it gets stored up in the liver. Fat is not supposed to be in your liver. It's supposed to be in the fat cells. They want to store the fat. It's safe in there. It's not safe to have fat in your liver. So the liver tries and tries to get it out, but because of the hyperinsulinemia, insulin is forcing all that fat and sugar back in. Now in Claire Johnson, or someone with lipodystrophy, there are no fat cells to store the excess fat, and so it has nowhere to go but the liver. So to protect itself from this toxic fat and sugar, the liver becomes insulin resistant. So the resistant liver starts spewing out all this excess triglyceride, and our blood TG levels go up. Classic metabolic syndrome. And as more and more of this excess fat is released by the liver, well, it has to go somewhere. It's moved around in the body to accumulate in other tissues. So that's how we get fatty muscles and eventually a fatty pancreas. As we've seen in another video, as the pancreas gets fat, it starts to produce less insulin and potentially even halt the production altogether. The pancreas is designed to protect us. If we have too much insulin, then there's no sense in creating more. So this hepatic IR and impaired beta cell pancreatic function results in increased blood glucose. But this is a response to too much insulin. Now the kidneys normally reabsorb all the glucose that passes through them. But when glucose levels rise too high, the kidneys cannot reabsorb it all. The natural response when this blood glucose gets too high is to urinate it out along with loads of excess water, resulting in weight loss. This is the body's natural way of lowering the blood glucose in order to reduce the blood insulin. All of these factors, obesity, IR, elevated TG, and beta cell dysfunction, are the body's protective mechanism against the same thing, hyperinsulinemia. But when we seek the help of a healthcare professional, they focus solely on the hyperglycemia. It's that symptom of T2D that is treated instead of the true cause. Now, before we move forward, let's look at what can be expected from a lifetime with T2D. As we know, we have many drugs that can very tightly control blood glucose. But even with this degree of control, we end up with damage to virtually every system in the body. This damage is known as end organ damage. There are two types of complication: microvascular, meaning small blood vessels, and macrovascular, meaning large blood vessels. Most organs, such as the eyes, liver, kidneys, and nerves, are filled with small blood vessels. So damage to these vessels causes the organs to fail. As we know, damage to large vessels creates plaques, which then rupture and cause blood clots, leading to heart attack and stroke. Now, there is a third category of T2D damage, but it's difficult to classify. So let's run through the list of diseases associated with T2D. Retinopathy. T2D is the leading cause of new blindness in the US since 2011. Retinal damage is one of the most frequent complications of T2D. The damage to the vessels in the back of the eye causes blood and other fluids to leak into the eye. Over time, this can lead to scar tissue, which then lifts and detaches the retina. This can lead to blindness. Nephropathy. Diabetic kidney disease is the leading cause of renal failure. This is defined as kidney failure needing dialysis or transplant, and accounted for 44% of new cases in the US in 2005. It's estimated that the cost to the US for the care of this disease is roughly $32 billion. Neuropathy. Diabetic nerve damage affects about 60 to 70% of all T2D patients. There are many kinds of nerve damage, but the most common is damage to peripheral nerves. This would include the hands, feet, arms, and legs. The symptoms, which are worse at night, include tingling, burning, pain, or numbness. Over time, there's a loss of sensation, which leads to joint damage and carpal tunnel syndrome. In some cases, it is the autonomic nerves that are affected. These nerves control involuntary functions like breathing and heartbeat. If they're severely damaged, can lead to sudden and unexpected heart attacks. Ultimately, there's no real treatment for this damage. It can only be prevented. Atherosclerosis. This artery hardening and plaque buildup leads to heart attack and stroke. T2D greatly increases this risk. The amount of death and disability from this macrovascular disease is far beyond that of the microvascular diseases. Heart disease. This is the most feared and recognized of all T2D complications. According to the American Heart Association, at least 68% of all type 2 diabetics over age 65 will die of heart disease. This percentage is so high that controlling CVD is the #1 goal for diabetic patients. Even so, a T2D patient is at 3 times more risk of heart attack than a non-diabetic. Stroke. This is the 3rd leading cause of death in the US and the leading cause of disability. T2D increases the risk factor for stroke by as much as 150 to 400%, rising 3% for each year with T2D. It's estimated that about 25% of all new strokes occur in T2D patients, and 16% of all type 2 diabetics over age 65 will die from a stroke. Cancer. Many common cancers are related to T2D and obesity. Breast, stomach, colorectal, and kidney are just a few. The survival rate of these for T2D patients is often far lower than non-diabetics. Peripheral vascular disease. PVD is caused by the blockage of blood vessels going to the lower extremities. The progressive narrowing of the blood vessels starves the legs of oxygen. Diabetes, along with smoking, is the strongest risk factor for PVD. Pain or cramping when walking is the most common symptom. Approximately 27% of patients will have progressive disease, which significantly reduces mobility, leading to long-term disability. Some PVD patients may suffer from the next end organ damage. Diabetic foot ulcers. Most foot infections are quite rare, except in T2D patients. This often leads to hospitalization and amputation. Even with tight glucose control, 15% of all T2D patients will develop a non-healing foot wound. This accounts for over 50% of all amputations in the US. Fatty liver. NAFLD, or non-alcoholic fatty liver disease, is caused by storage of triglycerides in the liver exceeding 5% of the liver's total weight. This is the leading cause of cirrhosis of the liver in North America. It's estimated that about 75% of T2D patients will develop this. Alzheimer's disease. As we know, this is a neurodegenerative brain disorder causing memory loss. It's also the most common form of dementia. The link between it and T2D grows stronger and stronger to the point of many wanting to classify Alzheimer's as type 3 diabetes due to the primary role of insulin resistance in the brain. So, why am I pointing out all of these horrific consequences to you? Well, it's not meant to scare you. I mean, most diseases affect one organ system of the body, but somehow T2D affects multiple systems all across the body. I mean, it's the leading cause of blindness, kidney failure, CVD, stroke, amputations, dementia, infertility, and nerve damage. This disease has been around for centuries, and yet this end organ damage is getting worse and worse. Why? Because our current treatment is flawed. The UKPDS, United Kingdom Prospective Diabetes Study, was undertaken to see if intensive blood glucose control would prevent all this excessive end organ damage. One group of patients was given tight blood glucose control using sulfonylureas and insulin, while the other group made dietary changes. It was believed that high blood sugar was the cause of all this damage and that this tight control group would fare better. The drugs significantly lowered the blood sugars. Over 10 years, the average HbA1c in the control group was 7% versus 7.9% in the diet group. However, weight gain was far worse for this group, and especially for the insulin group. They averaged weight gain of 8.8 pounds or 4 kilograms. This was surprising to the physicians at the time. They could find no benefit for CVD despite reduced blood sugars. In a sub-study, the researchers looked at metformin. Once again, there were 2 groups, one on metformin and the other with dietary changes only. Over 10 years, the HbA1c of the metformin group averaged 7.4% versus 8% of the diet group. However, unlike the previous study, there was a 36% decrease in the death rates and a 39% decrease in risk of CVD. So metformin fared better than SU and insulin, even though it didn't control blood sugars as well. So this implies that while glucotoxicity is a factor, it's clearly not the only factor. If we look closer at these results, what can we ascertain? What's the difference between an insulin SU group and a metformin group? And the answer is increased insulin levels. Both sulfonylureas and of course insulin increase insulin levels overall. Metformin doesn't. The problem is that after a 10-year follow-up of the SU insulin group, we did see a 13% reduction in death rates. While this isn't as good as the metformin group, it was good enough for researchers to recommend treating glucotoxicity for T2D. In 2008, the Action to Control Cardiac Risk in Diabetes, or ACCORD study, was undertaken to once and for all show everyone everywhere that controlling blood glucose was the answer. Other studies had shown that there's a link between lower blood sugar and better health. And this, of course, aligned with the prevailing theory that glucotoxicity is the main concern of T2D. While this worked for type 1 diabetics, the UKPDS couldn't show that it was effective for T2D. The ACCORD study hoped to show just that. There were two groups, a standard therapy with an A1C of 7.5% and an intensive group with an A1C of 6.5%. So we got the blood sugar nice and low in that group. But now we have to see some health benefits. And sadly, the intensive therapy group had an increased death rate of 21%. This group was following the advice that was given to type 2 diabetics by every doctor everywhere in the world. Lower your blood glucose as much as possible. And yet, they were dying at a significantly faster rate than those with loose glucose control. Due to this, the ACCORD study was forced to conclude 17 months early. It was clear that lower blood glucose with medications was not effective and even dangerous. But here we are, still prescribing insulin and blood glucose lowering medications to type 2 diabetics when no fewer than 6 randomized trials have confirmed that these treatments are largely useless for T2D patients. Are we really that clueless? I mean, we know from Claire Johnson that the real problem is high blood insulin levels as well as high blood sugar. So we must treat the high insulin. Raising insulin in an effort to lower blood sugar is not helpful and ultimately destructive. As organ failures and vascular complications get worse, we must accept that the current treatment for T2D is flawed. Focusing only on glucotoxicity from hyperglycemia as the only cause of T2D leads us to our flawed and dangerous treatments. These treatments undermine the protective factors we discussed in regards to obesity and keeps the excess glucose from being urinated out, continuing the downward spiral of the body that ends with organ damage and death. So, what would happen if instead of blocking this protective mechanism, you actually enhanced it? Well, that's the purpose of a class of drug known as the SGLT2 inhibitor. This type of drug lowers the renal threshold of glucose so that you do urinate out the glucose. Incidentally, this is exactly what happens in uncontrolled T2D. The EMPA-REG study released in 2015 used one of these drugs and reduced risk of death by 38% and risk of CVD-related death by 32%. Wow, it's amazing what we accomplish when we actually lower the blood insulin and glucose. Now, if we didn't treat the T2D at all, we would most likely have achieved the same results. Metabolic syndrome is marked by two main issues, glucotoxicity and insulin toxicity. We achieve nothing by increasing insulin toxicity to lower glucotoxicity. This is what occurs when doctors prescribe sulfonylureas or insulin. Of course, it makes much more sense to treat both markers of the disease. This is what the SGLT2 inhibitor drugs do, but diet can do this as effectively, LCHF and intermittent fasting. Ultimately, all of the aspects of metabolic syndrome, including obesity and T2D, are caused by the same thing. It's not insulin resistance, it's insulin itself, hyperinsulinemia. But doctors and specialists are slow to understand this and remain focused on the hyperglycemia and glucotoxicity. And of course, as we know, pharmaceutical companies are all too happy to help keep the focus here as well, since it makes them lots and lots of money. So, to sum up here, taking drugs to lower blood glucose by increasing blood insulin will ultimately worsen your T2D and most likely result in debilitation or death. You can fare well using a different class of drug that doesn't increase insulin levels, but why take a drug at all when you can affect the same changes through simple dietary intervention? Doctors are not trained in nutrition. Their job is to give you a drug to control your disease, and they're trained to focus on the high blood sugar and to treat that with drugs. This is perpetuated by the pharmaceutical companies that manufacture and profit from these blood sugar lowering drugs. But drugs have many numerous and serious side effects. Eating a low-carb, high-fat diet, and even more powerfully, intermittent fasting, is simple to do, highly effective, and lacks any serious side effects. If the result is that there is even a chance of reversing your T2D, as well as eliminating the potential of all end organ damage discussed previously, then the answer to me seems very obvious. But of course, you must ultimately decide for yourself. Now, if you're new to the channel, please subscribe and enable alerts so you know when new videos post. And if you like this video or any of the videos, please click the like button, as it does help. And please share the videos with anyone you think can benefit from the information. We need to help create a new paradigm for treating T2D that actually benefits those affected by it rather than those profiting from it. As always, from the bottom of my heart, thank you so much for watching. And until next time, keep being a loser.